Hey all, welcome back to the Real Life Pharmacology Podcast. Thank you so much for listening. As always, go check out reallifepharmacology.com. Get your free 31-page PDF on the top 200 drugs. Great study guide, great refresher. Definitely a great resource to have for any practicing healthcare professional who enjoys learning about pharmacology or feels like they need to brush up on their skills a little bit. So again, go check that out, reallifepharmacology.com. All right, so the episode today that I wanted to cover were two types of medications. So we've got one ezetimibe and the other PCSK-9 inhibitors. These two medications are, I wouldn't say crazy common in practice, but you do see them periodically for sure. And they lower LDL, and specifically, they are going to be used after and or in conjunction with statin therapy. So statin therapy, atorvastatin, rosuvastatin, those are really the go-to agents. Covered that podcast already. Go back, listen to that. Now, once we need more medication, LDL is not low enough, whatever the case may be, these two medications are going to be what's typically used next. So we're going to break down those two classes of medications. And first, I'm going to start with ezetimibe. This is the one that I see more often than the PCSK9 inhibitors. Ezetimibe inhibits intestinal cholesterol absorption at the brush border, ultimately reducing LDL cholesterol. That reduction is in the neighborhood of 15 to 25%. So the easy way to remember this is, take somebody that's at an LDL of 100, we're probably going to get in the neighborhood of a 15 to 25 point reduction on LDL if they're around 100. So I've got a case scenario coming up here at the end of this that I can kind of point that out and kind of depict a little bit more clearly where ezetimibe might be used. But again, ezetimibe typically not as strong as the high-intensity statins or the PCSK9 inhibitors, which can be 50% and even above that at times. So ezetimibe is often used as add-on therapy to statins when those LDL goals are not achieved, or in patients that cannot take statins for whatever the case may be. It's generally well tolerated. I've never really seen many issues with this medication. Minimal systemic adverse effects. Rarely you may see some GI upset, things like that. Possibly elevated liver enzymes, which is more likely in a patient taking a statin already. Big, huge advantage of ezetimibe compared to PCSK9 inhibitors is it's oral and it's once daily. So that's the huge advantage compared to PCSK9 inhibitors, which I'll get to in more detail. These are injectable medications that need to be given on a fairly routine basis. So that's the big upside with ezetimibe, and in my opinion, why clinicians and providers are going to typically go to this medication first to try to get that LDL further or to the desired goal that we're looking there. Again, that safety profile, generally very favorable as well. Can be combined safely with most other LDL lipid-lowering agents. So, fine with statins. May even see used with PCSK9 inhibitors as well. You may see some periodic liver function tests, particularly if there's clinical signs and symptoms of issues and or they're taking a statin-type medication. And then obviously we're going to monitor LDL as well there. So again, ezetimibe, it really provides that additional LDL lowering. It doesn't really impact triglycerides or HDL too much that way. So here, let's give you a quick scenario of what I see in practice typically. So let's say we got a 62-year-old male, history of hypertension, type 2 diabetes, prior MI, taking atorvastatin 80 milligrams daily, reports good adherence without adverse effects. Despite that high-intensity statin therapy and lifestyle modifications, most recent lipid panel still shows an LDL of 94. The cardiologists and primary care specialists, they want a goal of at least 70 here, less than 70 for that LDL, because they are at very high risk. Again, we mentioned previous MI there. So that LDL is still above goal, but it's not crazy far above goal, right? So we're at 94. We would like to ideally get down to 70 or lower if possible. So we've got 24 points to go down for that LDL. And again, that ezetimibe, 15 to 25%, that certainly lines up and potentially fits within this scenario. We're not talking about starting from an LDL of 150 and we're trying to get down to 70, for example. Okay, so that's kind of the situation where I would see you're most likely to see ezetimibe utilized. Now, there's other patient factors as well. Let's say you've got that case of 150 LDL even after high intensity statin. First and foremost, I would double check, triple check adherence and make sure the patient is actually taking it. If LDLs are still very, very high despite statin use, I've seen that numerous times, and numerous times that's been the case if you don't see that LDL come down. But in rare cases, that LDL can still be fairly high, even on high intensity statin therapy. So in that case, where we've got a lot more LDL lowering to go, that's a situation where you may see that PCSK-9. And again, I'll talk a little bit about that coming up here. All right, so transitioning into those PCSK-9 inhibitors, it's alirocumab and evolocumab. Those are the two agents that are available. These are monoclonal antibodies that increase LDL receptor recycling in the liver. And this leads to significant LDL cholesterol reductions, and that reduction can be in the neighborhood of 50 to 60%. So these medications, the PCSK9 inhibitors, they are more along the lines of high-intensity statin reductions for LDL. All right, so these medications, where are they typically used? In patients with familial hypercholesterolemia, established ASCVD who are not at goal LDL despite maximally tolerated statins. Again, this could be with or without ezetimibe. I have seen that as well, where we're on the high-intensity statin, we add ezetimibe, and still not really close to where we want to be. You may see a PCSK9 added onto that situation as well. Again, it's probably a situation where there's been, multiple heart attacks. They're very, very high risk, those type of things, where we add that many meds, but it definitely can and does happen out in practice out there. So pay attention to that. All right, let's take a quick break from our sponsor, and we'll wrap up with PCSK9 inhibitors and a quick case. If you're in the market for any pharmacist board certification study materials like BCPS, ambulatory care, NAPLEX, BCM, TMS, the geriatric exam, go check out meded101.com/store. We've helped thousands of pharmacists and other healthcare professionals prepare and pass their board exam, and we can absolutely help you too. So go check that out, meded101.com/store. Help to support the podcast and get some great content as well. All right, so moving on, finishing up with PCSK9 inhibitors, the big downside, these are administered by subcutaneous injection every 2 to 4 weeks. Okay, so that requires some patient education, injection technique instruction. We've also got some storage issues as well. So that's the biggest downside with these agents for sure. Generally pretty well tolerated. It being an injection, that's probably what you're most likely to get reported back to you from patients, are some of those injection site reactions. You may see some flu-like symptoms, things of that nature as well. Typically not associated with liver toxicity and myopathy and things like that statins kind of are a little bit more associated with. Not to say that they can't, rarely occur, but generally not to the extent and the rate that they occur with statins. All right, so in addition to the injection side of things, direct cost of the drug and insurance coverage can absolutely be limiting factors for the use of PCSK9 inhibitors. So, prior authorization and that whole insurance mess definitely does come up with these agents. So, be prepared to that if you're, prescribing or dispensing or, talking with patients about these medications. From a lab monitoring standpoint, obviously we're going to look at LDL, making sure that we're getting that patient to goal where we want to be. Typically, liver, kidney, generally we don't need to do anything routine there for sure. Obviously, if there's signs and symptoms of something wacky going on, we're probably going to get generalized labs and make sure things are in order there. So again, these drugs can be combined with statins, with ezetimibe as well, potentially other lipid-lowering therapies as well. But I did want to mention a quick case of situation where it's more likely you might see a PCSK9 inhibitor. So here we got a 58-year-old female, history of coronary artery disease, history of stroke, familial hypercholesterolemia. They are already taking rosuvastatin 40 milligrams once daily. That's the highest dose, high-intensity statin. They are also on ezetimibe 10 milligram once daily. Patient has been assessed. They are adherent to their medication. At least that's what we believe to the best of our ability. And despite that, the most recent lipid panel shows an LDL cholesterol of 146. Okay, they originally, before statin and ezetimibe, were at 262. Now they're at 146. So we've reduced it significantly. But clinicians, providers are looking for a treatment goal of less than 70 milligrams per deciliter. Okay, so again, we've got quite a ways to go, 146 to 70. You're looking at trying to basically cut that in half. So 146 down to less than 70. So given that elevated LDL, given the goal that we're trying to target to reduce risks, this is a situation where you'll probably see a PCSK9 inhibitor prescribed. All right, well, that's going to wrap up the podcast for today. Hopefully you picked up some practice pearls. Hopefully the cases were kind of integrating the knowledge and helping you understand it a little bit better and what's actually seen in practice out there. Do me a huge favor if you enjoyed this episode, leave me a rating review on iTunes or wherever you're listening. If you have any comments, questions, suggestions, definitely don't hesitate to reach out, mededucation101@gmail.com. You can connect with me on LinkedIn as well, Eric Christensen, PharmD, BCPS, BCGP. With that said, go support the sponsor, meded101.com/store. Your support there goes to help keep this podcast free and available for all to benefit from. So greatly appreciate that. Greatly appreciate your support there. Again, tons of different opportunities, tons of different things to look at meded101.com/store, whether you're a nurse, pharmacy technician, pharmacy student, med student, pharmacist out in practice. Again, tons of different content, books, study materials, all that good stuff. So go support the sponsor, meded101.com/store. With that, I'm going to sign off for today. Thank you so much for listening. Take care. Hope you have a great rest of your day.